Okay, good evening and welcome to our Airway Health Solutions conversation series with my partners in Airway Health, Karese Laguerre and Brittny Sciarra. Welcome, ladies. I feel like this is just a normal get-together. We get to talk about one of our favorite topics, which is merging Myo into the dental practice. And this is such a huge topic and very popular among dentists and dental hygienists, especially. So our focus today is really on merging Myo into the dental practice. So thanks, ladies, for joining us. And thank you, everyone, for attending. We have an exciting night ahead of us. But let's just take a few minutes for you guys to both introduce yourselves a little bit and tell us how you got started in Myo. I'm going to start in my upper left corner. So Karese, why don't you go ahead and kick it off and just tell us a little about your journey and how you went from RDH to myofunctional therapist.
So I'm Karese. I am a myofunctional therapist. I've been practicing and really focused heavily on helping as many people as possible because my journey started with being able to help my own family and really work within my home to resolve a lot of the issues that were present in my household that I was unaware were related to all of these oral things that were going on with my kids. So as a mom of 4, we went through all sorts of things, a myriad of things, and we've really come full circle. And so I'm happy to help as many people as possible to transform their homes the way I did mine.
And I have to share, before we get to Brittny, your book, I read it on a snowy Sunday. I forgot to even, I didn't want to bother you, but everyone has to read Karese's book, Accomplished. It really is a great read. It's a rewarding read as a hygienist and just as a human being, as a mother, as someone, as an entrepreneur. You really covered a lot of valuable topics and touched my soul. So I highly recommend that Accomplished book. So we'll send that link in the follow-up. But go ahead, Brittny, you're up. I know Karese is a tough act to follow, but so are you.
Oh, thank you. I'm Brittny. Nice to see everybody. I got into myofunctional therapy in 2016 on my own accord. Nobody got me into. I read it in a RDH magazine. Had no idea what myofunctional therapy was because we don't learn it in hygiene school. Dedicated to always learning more, doing more for my patients. I looked it up and I was like, I need to know about this and I need to know about it like tomorrow. So I went and I took the course, and as I'm sure all of you that have done some kind of continuing education for Airway, the light bulbs are like flashing everywhere and you can't wait to get, back to your practice to be able to start implementing everything.
Yeah, and I'm just going to add too, I actually took a course. I was trained in orofacial myofunctional therapy in 2013, but I knew I wasn't going to implement it. I just wanted to learn about it because too, I was fascinated by the root cause of disease. And so many people don't realize that it's soft tissue dysfunction is really the root cause. So we're going to talk a lot about that tonight because all of us, I think on this call, are really interested in comprehensive care and getting to the root cause so we can treat the cause versus the symptom. So let's take a few moments and just kind of dive right in and just give a little overview. Karese, were you going to kick it off and just kind of give an overview of what Myo is for those who maybe aren't aware of the science?
Sure, I would love to. If you don't mind, I'll share my screen. We'll do a little PowerPoint powwow. That's what we'll call that. From current slide, everybody can see my screen.
If anyone has questions, you can feel free to put it in the Q&A section. I have a lot of the questions that you already entered when you registered. So if additional questions come up, feel free to put it in the Q&A section.
Awesome. So when we think about dentistry and conventional dentistry as it is now, we're really thinking about what is going on currently with the patient and how can we deal with what's happening now and possibly some preventative things. So how can we prevent it from happening in the future? But when we're talking about like airway or functional dentistry or myofunctional therapy, we're always thinking about why. Like Lauren said earlier, we're talking about the root cause. So we're really going into the why this is occurring, right? That way we can kind of double up on our how and our what. So what exactly is it when we reference myo are we talking about? Because there's so many terms out there. There's orofacial myology, there's orofacial myofunctional therapy, there's oral myofunctional therapy, and there's just myofunctional therapy. Well, actually, all of those are rather interchangeable and all very much mean the same exact thing. What it definitely is not, and I don't want anyone to get confused with, is myofascial therapy or myofascial release. Those are two completely separate things. So while there are a couple of different names that are interchangeable, when I talk about it, I always like to use myofunctional therapy as the term because myofunctional therapy is so near and dear to me, coming from a dentistry background. When we're talking about it, we're looking at the history of it, and Dr. Alfred Rogers worked under Edward Engel, who we know is the father of orthodontics. And Dr. Alfred Rogers was a super prominent orthodontist at the time who was studying a lot of why malocclusion is occurring. So yes, Dr. Engel did come up with, all the different classification systems of malocclusion, but Dr. Rogers was looking into why is this happening? And he authored more than 50 articles on muscle training and how the impact of the soft tissue has on the hard tissue development. So a lot of our craniofacial development from when we are in utero even goes into how we are developing as we age, okay? And while that is the start of orthodontics, that is not where orthodontics profession is currently now. When we're thinking about it and where dentistry is now, I like this quote by Dr. Chris Farrell. He is a dentist in Australia. I think it sums up so perfectly where we are now, that the orthodontic profession has accepted that to expect case stability without using fixed appliances, without fitting permanent retainers, is both impractical and unrealistic. Like, we've come to the point where we're no longer thinking about function. We're only thinking about how we can, deal with things through a structural change using some fixed appliances. And that is not the origins of orthodontia at all. Dr. Edward Engel himself advocated for aesthetics and facial proportions. He wanted symmetry in the face. He wanted to get to a proper craniofacial development. But around the mid-20th century, things sort of started to shift, and we were looking more into getting to class 1. And then that's when we started to see extraction and retraction orthodontics. So that is not the history that we come from, but we have evolved, and now hopefully we're evolving on the way back. And so that is part of what we do when we're dealing with myofunctional therapy. So we have 3 goals with myofunctional therapy. One is to achieve a proper tongue resting posture. That's to get the tongue up against the palate, because where your tongue rests matters. We want that tongue to be lightly suctioned from the incisive papilla along the spot, is what we call it industry-wise, all the way through to the soft palate. And when it's there, and it's there consistently, that soft tissue pressure is going to help kind of mold and shape a nice wide palatal arch. So then you'll see that there will be a lot less crowding and more room for all the 32 teeth that we have that are supposed to be in our mouth to fit in. And when you don't have that, when you have the tongue sitting in an improper position, so when the tongue is sitting maybe a little lower in the mouth, like mid-mouth, or it's kind of sitting and resting in between the teeth, or it's resting all along that lower arch, you're going to see different developmental stages of the teeth. The teeth are going to change and shift their position, and it's going to cause a type of malocclusion, and it's going to alter the craniofacial growth. So it's incredibly important that we really focus on where our patients' tongues are resting. And the biggest thing, if I can tell you nothing else about myofunctional therapy, is that it's super collaborative. So while we have these goals of, yes, proper oral rest posture is the tongue up, the lips closed, and breathing exclusively through the nose, those goals can help if we get started early enough. But myofunctional therapy is definitely not magical. It is something that you do collaboratively with other professionals. We work in very close quarters with dentists, doctors, physicians, all sorts of people. And so it's incredibly important for everybody to understand that it is a beautiful thing, and you can change lives and you can do so much to help your patients, but there's a lot more to it. And Brittny, I think this is a good time for me to kick it over to you.
Thank you. That was wonderful. All right, let me share my screen. Can you guys see my screen? Perfect. Okay, so we're going to talk a little bit about the return on investment, because of course we want to know, why should we implement myofunctional therapy practices into our office, or why should we be referring outwards for myofunctional therapy? What is it going to do for us? What is it going to do for our patients? So first off, there's limited providers. Right now, there aren't a lot of us myofunctional therapists that are specializing in this. So that's going to increase your competitive advantage. You're going to see increased referrals. Those patients that are coming in, maybe some of those patients can be converted to your actual patients for recare and restorative. And some of those patients can be converted to your actual patients. Oh, that's okay.
I like to hear you both ears.
We are going to save valuable chair time, not having to redo restorations that fail due to parafunctional habits, for example. And it's going to differentiate you by displaying that you value the person in the chair more than the teeth. So regardless of whatever type of practice you have, we're going to briefly go through basically all of the types of practices, why you should include myofunctional therapy into your practice, and how that's going to improve treatment. So for restorative cases, you'll see less recurrent decay. Why? We're addressing that mouth breathing habit. We're getting them dominantly nasal breathing. You'll see less broken fillings and less crowns, having to redo crowns due to the less recurrent decay, and also due to them failing from parafunctional habits, because we're going to address that in their myofunctional therapy program. Orthodontics, we talk a lot about that on Airway Health Solutions, clear aligner therapy, or if you're doing, bracket and wire, less relapse. You're going to see increased retention. You also have decreased overall time spent in orthodontics, because again, we want to address that soft tissue dysfunction, because we know that form follows function. So we have to get to the root cause. There are some studies in here that I can always have Lauren send you the links to. We're not going to go over all of them, but basically just studies that are supporting myofunctional therapy in these various practices and treatment plans. Your cosmetic practices, we can help improve facial aesthetics, restore balance to the oral facial complex, promote lip seal, and help to promote facial symmetry. It's pretty awesome what can happen when all of our oral facial muscles are working in harmony. If you have a TMD practice or oral facial pain based practice, in myofunctional therapy, it's really important that we help to normalize that dental freeway space. We want to make sure when we are at rest that we have that 2 to 3 millimeters between our back teeth. We, again, focus on those dominant nasal breathing patterns. We're not going to have the mouth, hung open and that jaw receded back. We will help provide relief by promoting proper muscle function. That muscle function, if we can get, again, down to that root cause, we're really going to help these patients. Your perio practice. A lot of people don't realize that we can even help those patients with chronic perio. There's a great article that I have linked after this that we should definitely send maybe out to Lauren in the follow-up email that Karese did, talking a lot about the association between lingual function and patients with periodontal disease. So we know that our patients that have more of a mouth breathing habit, what it's going to wreak the havoc on their gums. So by establishing those dominant nasal breathing patterns and not having the open mouth posture, the reduced saliva, the exposure to more bacteria, we're going to see reduced inflammation. And what about the mechanical stresses of clenching and grinding on the teeth? We can help stabilize those by helping to reduce bruxism. In your sleep practices, myofunctional therapy aids in oral pharyngeal tone. That wonderful study that was done by Dr. Camacho stating that myofunctional therapy can help decrease the AHI 50% in adults and 62% in children. For your patients that are either on CPAP or oral appliance therapy, it can help increase the efficacy. It can help make it more comfortable for them to wear these appliances as well. We can help reduce, like we said, the AHI, as well as snoring and mouth breathing. Here's that wonderful article by Karese. If you haven't looked at it, you should. Oops, so much so that I'm going to zoom in on it. Another study, this was the one by Dr. Camacho. Another study talking about the effects of oral pharyngeal exercises on patients with moderate obstructive sleep apnea and saying how it does reduce the OSA severity and symptoms. Pediatrics, I don't think we even have to go into that. I think Dr. Boyd's going to hop on a little bit later. All we need to say, early intervention is key. The earlier that we can get to them, the absolute best. Surgical results. I like talking about this one, especially MMA, but let's talk about tonsil removal, adenoid removal. You can give patients the clarity of nasal space, but if it is a habit, if they have been mouth breathing for years, we have to change those habits. We have to work on breathing patterns. We have to work on oral rest posture so these patients can breathe through their nose. It's not just magic. Some ENTs, they want to wait like 3 months to see if the patient can transition back to nasal breathing. But I know Karese can agree with me on this. Quite often, we don't see that going back to nasal breathing. They don't just automatically start to breathe through their nose just because now it's clear. We have to reteach them these patterns and these behaviors. Frenectomies, we can have an entire discussion on why myofunctional therapy is so necessary pre and post to prep for frenectomy. But I kind of want to just focus on MMA surgery because I feel like these patients kind of get like, they always come to me when they're already in pain, they're, limited range of motion, they can't get their impressions taken for Invisalign because they can't open their mouth, whatever the case may be. These patients, like any other surgery that somebody has, needs to have, if you have a knee surgery done, you go for physical therapy, right? Everybody knows that. That's just standard of care. Think about what we're doing in MMA surgery. These patients need to be prepped properly, not only so they feel that they have somebody in it with them, so that we can empathize with them, help motivate them, keep their spirits up high. I think that that's so important when you're going through such an invasive surgery. But we also want to help eliminate whatever barriers we can prior to them going in and help to optimize their function as much as we can prior to them going into surgery. If they have tongue thrust.
I'm just going to interrupt you 1 second because I thought this may come up. Can you just explain what is MMA surgery?
Oh, I'm so sorry. Yes,
that's okay.
Maxillomandibular advancement surgery. Sorry about that, guys.
No problem. So they literally bring your face forward and that instantly will open up the airway.
Yes. And a lot of these patients, you want to think, why do they have to have that done? What went wrong? We want to get to that root cause. A lot of these patients that have the diagnosis of obstructive sleep apnea, what is the root cause? The underdevelopment of their jaws. So it's literally, like Lauren said, bringing everything forward. But we have to address the original soft tissue dysfunction that got them there to begin with. The tongue thrust, the tethered oral tissues, oral habits, lip incompetency, whatever the case may be. So we want to teach them those healthy patterns and things that they can work on being aware of prior to surgery. And then post-surgery, we want to maximize those benefits. We don't want to see these patients relapse. So having a myofunctional therapist on board can help prevent that chance of relapse, strengthening the oral facial muscles, increasing range of motion, working on, chewing and swallowing patterns, and that general overall oral rest posture.
Can you briefly explain the TOTS, the tethered oral tissues as well?
Yeah, so tethered oral tissues, we can have, so we know we have our lingual frenum, we have our maxillary and mandibular labial frenum, and then we have our buccal frena. These tissues can all be restricted. It can, prevent it can prevent a lot, but again, that's like a whole, I don't know how in depth you want me.
No, just an overview, because I just want to make sure that, some people aren't familiar with the terms.
Yeah, of course. So if we know that, let's focus more on tongue tie, because that's what, we tend to see more of. We know that the tongue needs to rest in the roof of the mouth, that tongue is that driving force to really have good palatal growth. And if we cannot elevate the tongue properly, protrude, lateralize, all the functions of the tongue that we need to be able to do, we aren't going to see that growth from early on. Or, if somebody goes through clear aligner therapy, orthodontics, and that tongue tie wasn't addressed, we're not correcting that soft tissue dysfunction. They aren't able to function properly because of these limitations. So when you think about form follows function, you also have to think about the limitations that you have. And one of those limitations can be tethered oral tissues.
And also the goal is to really be a nasal breather. So how are you going to do that when the tongue can't rest properly in the palate?
Something that I love, this like blows people's minds. I want everybody to hold what we call lingual palatal suction. It looks like this. So your whole tongue suctioned in the roof of your mouth. And I want you to try the back too, the tip, the middle, and the back, the whole shebang we want up there. And I want you to try to breathe through your mouth with your tongue up there. You should not be able to breathe through your mouth. It is when that tongue posture drops that we begin to mouth breathe.
I love that. I shared that with my patients my last year at clinical, and it blew their mind every time. It really did. It did.
All right, let me get out of here. Okay.
Okay, so you guys went through kind of the basics of Myo and why it's important in the practice, but who can do this? Who can do Myo? So let's talk about that a little bit, because there's some confusion around what it is, how you do it. We'll get a little bit more into the how with our Q&A section, but who can become a myofunctional therapist?
There are a number of professionals, healthcare professionals that can take a myofunctional therapy course, but primarily it is oral health specialists. So dentists, dental hygienists, speech language pathologists, or feeding therapists. So sometimes that's occupational therapists as well. So those would be the primary 4 occupations.
Great. And how does one go about implementing this into a dental practice? Now, I know we have a 2-day course on this for a reason, because you can't really explain that in a 10-minute presentation, but maybe you can just give a high-level overview to maybe make it so it's not so scary to try something new and to implement it into the dental practice.
Yeah, I mean, I think first and foremost, obviously take a myofunctional therapy course, but after that and the implementation of it, figuring out how the how the hygienist is going to be practicing, because it's very important as hygienists that we either wear our hygienist hat or we wear our myofunctional therapy hat. So you don't want to be flip-flopping back and forth. So figuring out if you're going to have, a certain day that you're going to do Myo, or you're going to clock in the morning as a hygienist, clock out, and then clock in the afternoon as a myofunctional therapist. I think that, like, first and foremost, that needs to be, discussed and developed between the dentist and the hygienist.
And what are your thoughts on that, Karese?
Yeah, when you're thinking about implementation can be done. It's just a matter of deciding how you would like to bring in this new referral, because essentially what you are doing in office is referring to just another specialist in the office. So it's just like bringing in another team member. If you brought in a periodontist or an endodontist, or you brought in some other specialist, how would you establish that in-office referral relationship? Where would that practitioner practice, and so forth? So it's very similar to integrating other modalities. It just has its own little twang to it.
And then making sure the rest of the office is on board and that everybody knows what their role is, and that the same message is getting, presented to the patient, regardless of whoever they're talking to, clinical, front office.
Well, that's what I love about the course that you two created with Airway Health Solutions, is that we really focus, and it's a specific niche, if you would, of specifically the dental hygienist or the dentist integrating this into their existing dental practice. Some of the questions just coming up in the chat is, how do you bill this out? Would this be charged out to dental or medical insurance? I know we get into the nitty-gritty, but just maybe we can touch on that a little bit.
More often than not, it is a fee for service, and I would anticipate that above all else. There are routes you can go, and we do talk about other ways that you can handle billing, but more often than not, you'll save yourself a lot of stress and headache and time by fee for service.
Okay. And let's talk a little bit about the virtual opportunity, because, we've seen this with COVID, and just people are getting used to these Zoom platforms. It used to be such a barrier in the beginning, but now it's like having an iPhone. You just go on your Zoom link and everyone's good to go. Can you talk a little bit about the opportunities to incorporate this virtually?
Yeah, I mean, I think it's vast. Some offices have patients driving 2 hours away because that's the closest provider to them. So, being able to offer these services virtually. And I think the technology's come such a long way. I mean, as far as if you want to talk about patient motivation and compliance, kids are already so used to being on Zoom, especially with the pandemic. But even as far as evaluating, like there's certain ways that you can go about it. People always ask, like, are you going to be able to see what you need to see? And something as simple as when you send them a link, having them log in from not only their computer, but also their phone. So their phone can almost serve as like an intraoral camera, because they'll be, obviously very much magnified. If they're in a well-lit room, if they have good internet connection, there really is no reason that we can't provide these services virtually. There are some myofunctional therapists that solely do myofunctional therapy virtually.
Yeah, and at Airway Health Solutions, I'm sorry, Karese, let me just finish this one thing. Brittny is a partner of ours, so if anyone wants to do telehealth, reach out to me at info@Airway Health Solutions, and we can connect you with Brittny. Go ahead, Karese.
I was just going to say that one of the things I love about our course is that we do that interactive where we're doing a teletherapy evaluation. So we do all of that troubleshooting and all of the looking and everything interactively live together collaboratively. So you get firsthand experience with that.
Mm-hmm.
Yeah, and I love the interaction. I love the comments from the attendees who've taken your course. They're very much, they feel, ready to roll. And some of them have taken other courses to start. This doesn't have to be an intro course. We do recommend this to any RDH or oral facial myofunctional therapist to continue their journey. We'll talk about that later. But there's another question in the chat, and then I'll address our group questions. It says, since speech therapists and pathologists or OT do this, is there a struggle to get patients to do fee-for-service versus medically possible, versus medical possibly paying? What are we able to offer more versus other providers?
There is not a struggle, because especially when it's in office, you're really selling that service. You're selling the value of that service. Very often, a lot of patients have no idea what it is that you're talking about, right? So when you start talking about their oral function, you're blowing their mind just from jump. They're not leaving now the office to go research, to go find another therapist that might be however many distance away. They're not doing all of that. They're sold. You sold them. You're in their office. You're in the face. They know you. They love you. They trust you. And they're most likely going to not give you pushback.
Yeah, and we talk a lot about that in the course as well. When we talk more on the business side of it, how to make yourself stand out and basically increase your competitive advantage if we want to get technical.
Yeah, and I see there's like very similar questions that are coming through, but let's see if we can tackle this a little bit, because there's not one way to do this. So let's just get some high level suggestions. How are the charges for fee for service determined? There's a lot by zip code. Is it kind of the going rate? And then how is the hygienist typically, I don't even know if there's a typical paid in the dental office? What are the different ways that you see in your experience?
So as far as compensation for the hygienist, I would definitely say that it is something that you can do one of two ways. It can be an hourly wage, or it can be a percentage, like a commission, very similar to dentistry, where some people make an hourly wage or you get a commission. How you break down your fees is probably going to determine which way you go with that. If you do like a bulk package thing, then you might want to aim more commission based as opposed to hourly and so forth. That can get very complicated. I will say that just like in dentistry, when we're thinking about our UCRs, you want to look at the usual customary and reasonable fees that are in your area for similar types of services.
Someone shared that in Ontario, it's in their fee guide, which is nice as well.
Oh,
so yeah,
absolutely.
Go Ontario.
Yeah,
so that's interesting.
Stuff.
Can myotherapy be easily incorporated into an older practice that still has paper charts and film x-rays?
Yeah, absolutely.
Right?
I started off just paper.
Yeah, I love paper.
Me too. Paper's my friend. I still write on it all the time, and then shred it or obviously import it into but 1000%. I mean, you're going to treat your myofunctional therapy patient records the same way that you would treat dental records. So there is nothing that will hold you back still being paper.
And on an existing, and RDH says, any tips on speech considerations, especially trouble with the letter R and the ch sound within myofunctional therapy? Oh, look who's joining us. Go ahead, answer the question, then we'll welcome Dr. Boyd.
think when there's specific speech concerns that it's important to get, our interdisciplinary team involved to get those speech language pathology referrals done. There are certain little things you can do that might help aid if they're already currently in speech, but I would leave that focus on articulation of certain sounds to that professional.
And I think, again, that interdisciplinary care and working with your patient's speech therapist, because certain exercises you might be doing with, your patient can go hand in hand with whatever the speech therapist is working on. So it's actually pretty cool when you can team up with a speech therapist.
Yeah,
absolutely. Welcome, Dr. Boyd. I'm so thrilled you're here. We're so thrilled to have you.
Thanks for inviting me. I'm sorry I'm late. I wish I could have watched.
No, it's actually perfect timing because we just finished kind of building a foundation of what myofunctional is, how you may incorporate that into a dental practice, who can practice it. So what I would like for you to share is how can you share with the audience your feeling and your philosophy behind myofunctional therapy?
Well, I really serendipitously came in to even knowing what it is. I had a child, a patient, maybe 15 years ago, a little kid who I was setting up for what I, at the time, considered really aggressive early treatment. I was going to treat him before the age of 8. That was real, that was out there. And they moved away. And then came back into my life, and I figured they'd move far away, and they moved back. And boy, the kid just, his mouth was a mess, and he just, oh my gosh, who did your ortho? And the mom said, nobody. We went to a myofunctional therapist her name is Carol Mayer. She's retired now. And I tell you, that started the whole, what in the world is myofunctional therapy? I just didn't know what it was. And the difference that it made on this one kid really changed the course of my career almost in terms of my protocol. I just don't even want to start a case. I do, but I'm getting to the point to where I'm going to probably incorporate at least an initial myofunctional evaluation on every single patient. And all I do is ortho now. I don't do restorative dentistry. There's enough demand now that I just, other people do the restorative, and there isn't that much. But in myofunctional therapy is just, it's making the results are just like I'm getting them faster, I'm getting them better, they're more stable. And, I use a number of myofunctional therapists, from dental hygienists to speech pathologists, and even Jenny Hobson, you may know her, she's a physical therapist who is a myofunctional therapist. So I'm just so sold, and I'm determined to tell the world about you guys. I mean, you're doing amazing things, and I'm so pleased. There's almost 100 people here that are interested in this. So
yeah, and actually, you're going to sign up your hygienist to do this into your practice for their course. So
yeah, I'm hoping it's already done.
Yeah. Consider it done. Consider it done.
I was going to say, if it's Lauren, I'm sure it's already done.
Yeah. There was a question, Dr. Boyd, that maybe you can answer that was geared towards considering fixed expansion with children. When is the best time to begin myofunctional therapy?
Well, myofunctional therapy, they call it re-education, right? Which means at one time there was an education, that something was educated, and somehow they couldn't advance to the next grade. I mean, I don't know, but continuing with that metaphor, the whole speech and swallowing mechanism, certainly not speech, but the actual apparatus for speech, it begins in utero, and, swallowing and chewing amniotic fluid. So, the best time for myofunctional therapy is when myofunctional disorders, OMDs, are actually detectable. Now, I'm getting really much better at it, but if you look at any child, any infant, even without teeth, if you see a deep, narrow palate, there's an OMD there, orofacial myofunctional disorder. So the best time to start is really when you recognize there's a disorder, but who are you going to send them to, and how many myofunctional therapists are actually comfortable and competent treating infants and toddlers? And I don't know the answer to that question. I happen to have a number of them in Chicago, so I'm very lucky.
So is it safe to say the earlier the better?
Oh, on 100%, and that's not even early enough, you know. So
Right. Okay. And what do you do about compliance? I'm going to start with you. I'm going to go around the board here. What is your experience with, because the therapy is only as good as the patients who comply. So you want to just, we'll go around the horn a little bit. Karese, why don't you start with your experience with compliance? Let's do it with children and then we'll do adults.
okay. Compliance with, did you want me to talk first?
It's okay. You know what? It's an open forum. Go for it. Go for it.
Oh, okay. I mean, I got compliance is what pediatric dentists are all about, and we have to develop competence in helping child become all that they can be in terms of, you know, being cooperative and obedient. And I always say kids, you know, they're hardwired to be obstinate and terrible twos, and they're also hardwired to be obedient. They just are. They have to acquire their culture throughout human history. Or we're here. So it's obvious babies, you know, they must be hardwired to be able to be, but they look to their adult caregivers, their parents. And if the parents don't see myofunctional therapy, early treatment orthodontics, you know, anything, if the parents do not see that as something that is gonna really be a component of good parenting, like this is, you know, figures into my child's ability to live well at the present moment and to live long and to live healthy into extended life. You know, that's how I prepare people. And if they're not ready, I'll just say, you know what, your kid biologically really needs this. They will benefit from it. But, you know, I'll say it to the mom, but the husband is no, Boyd's too aggressive and he's not really an orthodontist. You know what, we're not ready to start. I won't say I won't start. I'm just saying we're not ready because the child's going to pick up on it and they won't be cooperative. That's a best kept secret in orthodontics and maybe myofunctional therapy. You get the parent to understand the component of, you don't say, you know, it's good parenting. They just figure it out. It's their idea. Mm-hmm. And then you get cooperation. It's amazing. It really is.
And how many years have you been treating children?
Well, I've been treating kids for 32 years, you know, since I finished my residency, but never did I, you know, get so comfortable treating 2, 3, 4, and 5-year-olds until maybe 10 or 12 years ago, when I found out, you know, what I was doing was treating something that will not get better. And well, you can do it when they're older. Yeah, 7, 8. And you heard me say it, that's a geriatric patient to me. But what we like to do is manage the malocclusion and the OMDs, orofacial myofunctional disorders, as early in a child's life as is feasible, because it's not going to improve on its own. It's only going to get worsened, and it can correlate with, you know, neurological problems, inattention, lower IQ, risk of cardiovascular disease. New paper just out on that. If a kid has sleep and breathing disorders in early childhood and it is allowed to persist, they can, in later childhood, develop heart disease like an old person. Mm-hmm. So high blood pressure is how it starts. So that's why I take it very seriously, and I know you do too. And I'm just honored to be here. So
thank you. All right, Karese, why don't you tell us a little bit about your experience with compliance and maybe a trick or two?
I agree with Dr. Boyd that you have to get the parent involved when it is a child, right? And there has to be some sort of motivation or some sort of reward at the end of it all. We do little rewards in the program, or maybe they get points and the points lead them to my little prize bag, and then they get to pick a prize or something like that. But there's usually some type of engagement of the child, but the parent's not sold 100%, you won't get any sort of compliance at all. When it's an adult, I have to lay it out from the get-go. It's a commitment. I liken it to personal training. If you sign up with me, I'm like your personal trainer for your face, but you won't get any results whatsoever if you sign up and you don't do the work. You got to do the work. You want to lose the weight, you got to do the work. You want to get your function back, you got to do the work.
Can I use that personal trainer for the face? I love it.
Yes.
That is great. That is beautiful.
Brittny, how about you?
Yeah, I mean, I totally agree. The parents definitely have to be on board. Something that I found over the years, when I first started myofunctional therapy, I used to offer patients to pay by session. And I found that when I presented it more as a program fee where they had to make that commitment up front financially, they took it way more seriously. Not all of them, but most of them. I also think, we have to, like Karese said, figure out what motivates our patients. So like, are they internally motivated or externally motivated? Examples of those would be like, if we're talking about kids, if a child reads a book because they like to read a book, well, that's internal motivation. If they read a book because they know when they're done with their 20-minute time, mom and dad's going to come in and hug and kiss them and tell them how proud they are, that's external motivation. So you have to definitely learn your patients, learn their dynamics, the family dynamics. Definitely make sure mom and dad are both on board, especially if it's unfortunately a divorced family, because if they do the exercises with mom, but then they're with dad, even if they're only with dad every other weekend, they need to do their exercises every day. Everybody has to be on board.
Right, great point. A question from the chat. So how does age affect outcome, and what age demographic primarily benefits from your therapy?
We treat patients of all ages. The oldest patient I've treated for myofunctional therapy, I think, was 74. Of course, like anything, age matters. When they're younger, we're still forming and developing and whatnot, but it's never too late.
Absolutely. When they're younger, you're going to see a lot more dynamic change because they're still developing. You still have that growth potential as they're younger. So if you're working with a 5-year-old, you're going to see a lot more shifting and changing than you would if you're working with the 88-year-old. It's not going to move and shift the same.
Oh, yeah. But what's really great about working with adults is the feedback that they can give you. Like, I really enjoy working with adults because they're so in tune with their bodies and what exercise might have worked better for this versus that. So you definitely can get more feedback from adults. So I love working with all patients.
Mm-hmm. And I know, Brittny, I think you experienced this firsthand, perhaps, is how to manage offering OMT services privately to your patients if your doctor isn't on board. Is that possible? Well, that's like a slippery slope.
You have to have that conversation with your doctor off the bat. Some doctors, not that they're not against it, but they're not really for it, but they might be comfortable with you maybe presenting a little bit of the information to your patient and giving them either like an email address to contact you. If you want to learn more about this, reach out to me. But it is tough. It's tough to work in a practice where you don't have that support from the doctor. We actually just talked about this in a Q&A the other night, actually. So biggest piece of advice, talk with your doctor, let them know that you're interested in all of this and what you're seeing. And you know what? It's a good time to educate your doctor too and get them on board.
And then how about if someone wants to do this, how do they present this to an office? Can you speak to that, Karese or Brittny?
I think the important part is to know what the office wants to get out of any type of presentation about it. So there are some that are very single focused. If you're talking about a pediatric office, maybe they want to know specifically how this would work for children, what it does. They don't need to know about, compensatory patterns that when you're in your 30s, you're going to see the results from. Nobody wants to know about that. We're focused on pedo. So you want to stay in the same vein with your education, and you want to make sure that you ask the question, what is it that you would like to know about myofunctional therapy? How can I help you learn? That way you can really cater it to them.
Right. And then it's the opposite many times. I know Dr. Silver just chatted that she has the opposite problem. She's the modernist in the myo, and she needs a committed hygienist. So there's definitely a need for myofunctional therapists. And I always like to connect the dots because I see so many hygienists who just want to do something different. Maybe they've done this for 10, 20, 30 years, or maybe even 2 years, and just want to expand their scope of practice. The good news is you can, and it's so rewarding that, why limit yourself just to caries and periodontal disease, especially when oral functional disorders can actually increase the caries rate. You want to talk about that, Dr. Boy, a little bit? I know I'm putting you on the spot, but I'm going to rephrase that question. Can you tell us how caries and periodontal rate and malocclusion is really related to the oral function, soft tissue dysfunction?
Well, oh my gosh, that's a very complicated network of events.
Yeah.
The the one attribute that, if you want to just oversimplify,
Yep.
we must establish nose breathing as soon as possible, as soon as a kid's life is as is feasible. Now, feasibility, did the parents live nearby? Is there, transportation? Do they have resources? Can they, are both parents on board? Nose breathing, just really tongue space and nose breathing. It's really, everything boils down to that. And, if a kid has a crummy diet and, is eating a lot of processed food, well, they're going to be susceptible to perio and to caries and to obesity. And, so you can't ignore what's going into that kid's mouth. But even, even COVID, if people are anti-maskers, if they're breathing through the nose, do you know that nitric oxide is a potent toxin for coronaviruses? Who knew that? There's a lot of papers on it too. Now, I don't know if it's going to go after the Delta variant, but you can minimize risk of failure just understanding the multifactorial nature of all these problems. But what these kids don't need is the inability to breathe through the nose. They're going to have a much better chance at having a healthy mouth and a healthy body. But realizing that there's other factors, it's the food that they're eating, the physical activity, and the sleep, the sleep quality. So I don't know. That's kind of general, Lauren, but I don't know how.
I'm glad. I do want general because we don't want to go down the rabbit hole. There's so much to learn. And that's why we have so many courses to really dissect this fully. But a common question I get, and I experience this firsthand as a hygienist, is what can the hygienist do? You don't need to become a myofunctional therapist per se to recognize these disorders. You don't have to diagnose myofunctional disorders. You can do such a service to your patients by being just aware of airway health. And a lot of it, maybe I'll do a separate webinar on just that, just clues from the hygiene chair to recognize airway disorders. So Karese and Brittny, what is your experience with that as a hygienist? You weren't always a myofunctional therapist, but you could certainly see some of the telltale signs, like we talked about, the high vaulted palate, the enlarged tonsils, the tongue tie, the abfractions, the recession, the cold sensitivity. Actually, you can trace that all the way back to underdeveloped jaws many times.
Definitely. I mean, I think that I remember that's one of the reasons I wanted to take the myofunctional therapy courses. You see things and sometimes you see them time and time again, and you want to know why you're seeing them. Like, why does this patient keep breaking their crown? What are they doing? Are they literally chewing rocks? Like, what's going on here? And I can remember this patient clear as day, and there's not a doubt in my mind that if he had a sleep study, and I sure hope he did in the last 10 years, that he has obstructive sleep apnea. There is no way that this man's airway was open. So I think being able to connect those dots is so important. If you don't want to be a myofunctional therapist, that's fine. But to be able to pick out the signs and symptoms that signal an airway issue, it's just so critical.
It's
Absolutely.
life-changing for the patient. I would liken it to why we screen for oral cancer, why we do oral cancer screenings. We're trying to look for things and notify the patient if we see something. So you're not treating the oral cancer, but you are there to help intervene. If a patient needs help, you can help change their life and impact them in a different way.
Absolutely. It's so
I can tell you a little experience, and I'm so glad you really asked that question, Lauren. I've sat on the boards of both major, certified, the AAIOM, AAMS, and I bring it up, and I'm really not on anybody's boards anymore. But I'm members of both groups. I brought up physicians have physician's assistants, right? Dentists have dental assistants. Why is it that a myofunctional therapist can't have a myofunctional assistant? And that's really without
pie in the sky. That would be wonderful, right?
Well, no, but boy, do I get pushback from the leadership of both organizations. Oh no, and it's like, no, oh yes. There's not enough myofunctional therapists to go around. And if they could be trained to help execute a treatment plan, just like a physician assistant does and a dental assistant, the expanded duties, they can do so much. My speech pathologist, do you know that there's a speech pathologist, SLP assistant, that you can actually become one of those? So for me, I think what you and Ben are doing at AHS by, providing this course, but not saying, you have to, become a myofunctional therapist. And no, you don't. You can become competent at assessment. And that's what my dental hygienist wants to do. She doesn't want to be a myofunctional therapist. I mean, she might. But,
that's what I did. I didn't become one, but there's certainly value and there's certainly a need. So you can get that return on investment. It could be a win-win,
Well, it's going to help the doctors a lot if a hygienist does more than polish, does cleanings. I mean, hygiene doesn't mean clean, it means health. And this is overall health. So I love it that you're doing this, and I wish more people would. So
thank you. We have a question from I think Dr. Silberg. Is the microbiome in the plaque affected by nasal or mouth breathing affecting oral systemic health outcome? You want to take that, Dr. Boyd?
Well, absolutely. If the plaque is, you've got anaerobes and aerobic, microorganisms, and mouth breathing definitely affects the bonding to the pellicle. It's an irreversible bond. There's two things, plaque, like not all plaque is created equal. Our ancestors before agriculture, they had plaque on their teeth. It's fossilized. It's called calculus. And we can analyze 10,000, 100,000-year-old plaque in teeth. It didn't cause caries. Caries doesn't appear in the human experience till about 10, 12,000 years ago, and appreciable. And really, there is recession, but it isn't, plaque related in pre-industrial people. So it absolutely can affect the oral microbiome. That's a given. Kids are more resistant to tooth decay, even if they're eating crap. If they're breathing through their nose, the caries. It's called an irreversible bond. Is that strep mutant strep? That's what they do. They poop out the extracellular polysaccharides onto the teeth, but you can brush it off with a toothbrush. But once a fermentable carbohydrate enters into that, then it becomes irreversible. If you're mouth breathing, it's going to happen even faster, that you get irreversible adherence of that plaque, that acid secreting plaque, to the teeth. And who knows that? I memorized that for a test in dental school, and I couldn't explain that until 10 years ago, when I got asked that question before. So that's that common knowledge.
I'm glad you're on. Just a quick question from the chat is, Karese and Brittny, I'm going to gear this to you. What bachelor degree do you recommend for hygienists wanting to pursue myofunctional therapy? It's kind of a trick question, I think.
You don't need a bachelor's
Right,
degree.
there you go. That
But
was
if
easy.
you want
Right?
one, I would say anthropology, but I'm biased.
Okay, well, I'm glad we answered that. And about 20 of our questions are having to do with how to implement this. So I'm going to go ahead and go to just the PowerPoint on the upcoming course and how they can learn more about this. Okay, you guys can see my screen. Before we do that, we always like the doctor to be on board. That's why we developed this myofunctional therapy course, because Dr. Boyd and Dr. Moralia think that myofunctional therapy is necessary. It's not optional to have success in your cases. But if there are any dentists who are interested in incorporating Airway into their practice, we do have our mini residencies, which is, I know Dr. Boyd, you actually have taken Ben's pediatric mini residency. You want to just talk a little bit about that from your perspective as a colleague? Yeah,
Ben, Ben and I kind of started this journey together at New York University at the AAPMD, and we both were invited speakers. And I hadn't heard Ben speak in a number of years. And one night I went online and something he was talking about, and it's like, oh my God, this is like, it's about time. And I just said, I want to teach preschool. I'll be the preschool teacher. I want to work with Ben. because and we really talked about to do my course, I want you to take Ben's course. I want people to have his background. It is so in depth, but he presents it so simply. It's so easy to understand. And he's got results. We both have really good results, which enables our confidence in the way we present material. So yeah, I would encourage anybody, tell them about how to link to that little sample that he gives, because
Sure.
you'll be
Yep.
hooked. He's awesome.
Absolutely. And then we also have our adult mini residency where we'll go into removable expansion appliances, clear aligner therapy to create more room for the tongue, all that so we can become nasal breathers at any age. So for more information on that, I'll send it up in the follow-up email. And then we have we still didn't change that picture, Brittny. I'm so sorry.
I give up. I'm over
this
it.
beautiful updated headshot, and for the life of me, I must be presenting the wrong deck, but that's okay. It's still a beautiful picture, but
Thank you.
it's even more beautiful if you can imagine that in the updated headshot. But let's just talk a little bit about our course. Let's talk about how it's different, maybe from other courses, and probably what they should expect after they take your course.
Sure. I think the interactiveness of the course, I love especially. It's so much fun. I mean, we're on there a lot together, a lot of the more didactic, foundational education stuff, whatever you want to call it. You get that material to watch ahead of time. And then like when we are on for those 2 days, we are on and it's engaging and you will be like ready to go and super excited and ready to implement by Monday. And, we try to stay as active as we possibly can in the group with you guys. So definitely keep commenting we have a dental sleep toolbox group for the graduates that you get access to, or we have that ongoing support. We want we want you guys to ask, questions about patient, put up case studies as long as you get the permission from the patients, whatever questions you have on there. It's such a great learning opportunity for everybody because a question you have is probably a question somebody else has.
Absolutely. And Karese, what prompted you to want to make your own course?
Oh, there was so much that I felt was missing because as hygienists, we are more employee based and we're not really seeing how we can be a partner in the practice, right? And so when we are putting on that different hat and we're collaborating in the dental practice to start up this new thing to help our patients in a different way, you're collaborating, you're a part of the interdisciplinary team. You're not just referring to it, you're not underneath it, you're a part of it. And so there was so much that was missing from just learning myofunctional therapy to actually being a myofunctional therapist. It's two entirely different things. And so that was a big part of why we implemented so much of the actual interaction and active clinical steps you can take. That way you are ready because it just isn't available anywhere else.
And we specifically made it only for dental professionals on purpose. So we're all speaking the same language. We all kind of had the shared experiences and we know how a dental practice runs. So I think that takes a lot of confusion out. It takes out a lot of maybe double learning. We already know the anatomy, but we offer modules on that as a brush up. So I think for me, I like a 2-day course where I can roll up my sleeves, dive in and get the job done and integrate it right away. That's my style of learning. Other people have different styles. So I love that you offer this as a 2-day virtual program where you can literally gain these skills and then practice them and then have the community, just like we do with our mini residencies as a follow-up. You have the quarterly town halls, you have the community that your questions can be answered. So I'm really, really proud of the course that you guys created. I do think I have the wrong slide deck, but while this lovely photo just popped up, I know this is one of my favorite photos of Dr. Boyd. Dr. Boyd, why don't you tell us a little bit about your course? We're super excited. First of all, we're so excited because it's live and it's also offered virtually, and especially excited because it's in sunny Florida, yay, on the beach, on the ocean. So there's so much good about this course, but why don't you tell us a little bit about this course that we're offering, and Dr. Darius Longmany also as a special guest. I know I'm thrilled to have you both there teaching our doctors. So tell us a little bit about that.
Well, Dr. Darius is a board certified pediatric sleep medicine specialist. He's also a pediatrician. And he and I started working together. And it's just the way I feel about myofunctional therapists. I just would rather not work without them. And Darius, who's just a brilliant sleep medicine physician, over a course of about 2 years working together at Lurie Children's Hospital, where we're both on staff, he's like, I cannot believe that this was not part of my repertoire, having, dentistry. And I've taught him a lot of dentistry. He's taught me a lot of sleep medicine. So the course is going to teach you how to get access to a sleep medicine specialist. And, you can see how we developed it. And not only are we going to give you our expertise and show you results of collaborating together, but we're going to learn from you. We call it a mutual learning network. And we get so much. I mean, even like right here, the Q&A, yeah, we learn so much from our students. We're hoping Lauren can maybe bring her niece or stepdaughter or something. I mean,
my grandchildren.
Yeah, we want, I don't have a Florida license, but we don't have to really touch the patient. I do a lot. We like to teach and role play, and we like to have some patients to demonstrate. We'd like to break into some groups to have little discussion groups. I'm going to be talking about my technique, which is something that I really don't do a lot of. I talk a lot about why it's important, because it's just, how do you convince people? Why should you expand a 4-year-old? Are you kidding? You can do it when they're 12. And, so I have to lay that background. But most people, especially if you've taken Ben's course, you're not going to need all that from me. And I can spend much more time showing you my cases, and showing you techniques, and how I collaborate with other healthcare professionals, including myofunctional therapy and sleep medicine. I don't know. Is that a good synopsis?
I think so. I mean, it just people wanted to know how you do what you do. And that's why we created a technique course similar to Dr. Moralia. He's been lecturing for years on the why and raising awareness, but it always came down to, well, how do we do it? So that's why we created the mini residency for you as well. And I'm thrilled by it. I have the right slide deck here now, so I apologize, but let me go ahead and just here's an overview of a little bit more nitty gritty about the myofunctional course, about the day 1 and day 2. I know as hygienists, we tend to be detail oriented. So you guys want to speak to this a little bit so people understand what we're offering?
Yeah, so day 1 is a lot of, we're going through just a lot of the basics, the foundational tools. And so you'll go through all the exercises with us. You'll have time to be able to practice that and to really get confident with it, because by the time we hit day 2, we're interactive. We're case and treatment planning together. We're talking about how do you implement this into the practice? How do you talk to patients about it from the hygiene chair? We're really getting interactive so that you can go from all that confidence you build up on day 1 to competence in day 2, and then you can efficiently go forward into your practice and really implement.
Absolutely. And then Karese, Brittny, wanted to touch on that a little bit?
Yeah, I mean, Karese really nailed it.
We'll move along. But we also offer 20 hours of CE, including the pre-learn modules, the certificate of completion. A common question that we're getting, and I just wanted to address it because I must get this question every day, is about being certified as a myofunctional therapy. I just want to clarify that you don't need to be certified. There's no body of certification right now. It's in the scope of practice for dental hygienists, dentists, SLPs, etc. But we do offer a certificate of completion, so you will be an orofacial myofunctional therapist. Brittny and Karese just created a new certification with the myofunctional airway specialist. So if you're looking to get more credentials, you can, you're eligible for that certification after taking this course. And basically, any therapist can be a wonderful provider with or without certification. So I don't want it to be a roadblock for anybody. But the more you learn, the more you learn from, the more mentors you have, the better clinician you're going to be. We don't advocate one and done. but we think we're a great foundation, especially for dental professionals. So we do have a special offer for attending tonight. And if you're an existing OMT, email me and let's chat, because we can create a customized pathway so you can also gain so many insights from Karese and Brittny on myofunctional therapy, as not as an intro course. If you have multiple hygienists in your office, we're going to offer a 50% discount off additional team members. So if a dentist wants to take it with the hygienist, the second team member would be at a 50% price range. So we're going to send that out in our follow-up email, because we really, really want to get myofunctional therapists on board, especially in the middle of the country for some reason. It seems like the coasts tend to have more myofunctional therapists, but the middle of the country is lacking. And that's where we can actually utilize Brittny, as I mentioned, for teleoral health myofunctional therapy. So reach out to me if you're interested in using those services. And this is, we covered. We also have an advanced mini residency with Dr. Moralia. So we will talk about that another time, because we have wonderful conversations coming up. And we're really excited. Next Tuesday, or I have a typo, January 25th, we had so many questions like tonight that we didn't have a chance last time with Dr. Moralia's conversation. So this segment on the 25th is just going to be Q&A. So tune in. That should be a really lively discussion. It'll be like a mixed bag. And thank you, Dr. Boyd, for coming back on Wednesday, February 2nd. We're also going to just pose the question, is there a right age to start interceptive ortho? So that's going to be really interesting. And February 28th, Dr. Nelly Silva, it is Heart Month. So we figured let's talk about airway and heart health and that correlation. March 15th, we're going to have Dr. Michael Gelb talk about treating the TMD patient. And Dr. Hal Stewart is going to join us with airway-centered restorative dentistry. And then April, we're having Dr. Susan Maples, and she's going to talk a really important topic about the impact of allergies on pediatric airway disorders. So as I always say, we'll continue to do this as long as we have the interest, and you guys are really listening. I really applaud you for your commitment to patient care and comprehensive care. We do have more live events coming up. The Dental Festival in Nashville. We're going to have an Airway Health Solutions Conference. Dr. Boyd will be there, Dr. Moralia, Karese, Brittny, myself, really to get the team on board with airway integration. And July 9th, we're doing Clear Aligner University to get your clear aligner business in line with airway and get that rolling. December 1st through the 3rd, we're announcing our first annual, fingers crossed, Airway Palooza at the Westin in Savannah, Georgia, where we're going to have multiple experts under one roof. It'll be a great social event along with a lot of learning. So if you're looking for an airway dentist, or if you're a hygienist who's looking to find a doctor who's like-minded, or if you're a patient perhaps, go to our airwayhealthsolutions.com locator, put in your zip code, and maybe you can find someone you can collaborate with, or if you're a patient, find care that you need. And then we do have our Facebook group once you take our courses, but I know we're over time, but there's always so much to talk about, you know? There's always so much to talk about. So let's close this out. There were some extra, some questions that we didn't get to answer. I think just one was preference on certification versus not. I'm going to say that's a personal choice, right? It's really, some people want that extra certification. It's not necessary. So we offer both. We just basically want to keep helping our patients breathe, sleep, and thrive. So any closing remarks that you guys want to share? I know we're up at 9:08, but just you can do it.
You can do it.
1,000%. And we're excited to be able to be alongside with you, helping you and mentoring you and watching you grow and just impact so many lives.
Absolutely. Dr. Boyd, thank you for joining us. We always love having you. Thank you for your insights. We look forward to hosting you in a couple of weeks. And hopefully we'll see everyone Tuesday with Dr. Moralia for the town hall. We'll send all of this follow-up information in the email with the email that you registered with. All right. Thank you, Karese.
Have a good night, everyone. Thanks.
Thank you for sharing your time. Bye-bye.